I'm Arlen Meyers. I'm with the Society of Physician Entrepreneurs and work with MI10. Anthony, you want to introduce yourself?
Hi, everyone. I'm a practicing cardiologist and also part of MI10 and also lead the AI Med 25 meeting.
Yeah, and if you haven't already signed up or are aware of AI Med, you can see it on the screen. Go to aimed25.com and it should be a great meeting again. Thanks to Anthony and his team in San Diego, the 10th to the 12th. So, without further ado, let me introduce our guest. Susan, you want to introduce yourself?
Yes. Hi, my name is Susan Gunduz. I'm a practicing pediatrician. I have my own practice. I started out of residency when I finished at NYU, and it's still going really strong. Most practices have been bought out by private equity, insurance, etc., hospitals, but I have been able to manage it very well, and it's profitable. But I'm here today to talk about my program that I started called Soundwise for Kids. And what I saw during COVID, I didn't close my practice. So I had a lot of time to think. And I found that a lot of parents were very upset about their children struggling in school. And then most of them were coming to when their kids were in fourth grade. When I investigated it further, I found that the kids were not really identified until third or fourth grade. And the parents were told at that point, which is really too late. The kids are far behind, hard to catch up. So
Let me just interrupt you for a minute and sort of tee something up, and then we'll look forward to your presentation. So there was a recent discussion about this whole issue of primary care and what are the operational failures of primary care physicians. And we can put the link to this in the chat. And incidentally, if you have a question, just put it in the chat and we'll ask Susan to address it. But so basically, this comes down to these things. And as you can see, it really has to do with disruption of workflow, requiring workarounds, and then it just actually adds more time to taking care of patients rather than less time. And it just kind of disrupts the whole workflow and process mapping in a practice. And this alludes to the fact that the basic model these days of digital transformation in a practice is referred to as people, process, and technology. So do you have the right people in the practice that understand how this is working? Is the workflow process optimized? And the issues that have to do with the technology. So that having been said, Susan, why don't you walk us through the problem that you're trying to solve and how you did it, and what have been the results?
Okay. So what I did is I did an evaluation of how to help these kids who were struggling starting in fourth grade. So I interviewed parents and teachers and developmental pediatricians, and I found there really isn't any real strong screening or evaluation program early on before preschool or kindergarten in all the developmental domains. So then I did my research. I spoke to a lot of different people, physicians, teachers, administrators, and I put together, I said, well, how am I going to solve this? So I put an assessment together on a piece of paper just for fun to try it out. I put a piece of paper with drawing and different words and put crayons on the table. After my physical, I had the kids go at it. Okay, draw a circle. What color is this? Show me the shape, show me the circle on top of the square, like spatial relationships. Then I, assessed their fine motor. I had them hop on one foot, skip, try to throw a ball, check their gross motor skills. And then their speech and language, receptive, expressive, ability to say letter sounds, to decode. And I did this in the office in front of the parent and in front of me, and the kid demonstrated where the developmental gaps were. Instead of giving a questionnaire to a parent, if people have kids, they're familiar with the screenings that pediatricians give out, and the parents check off yes or no. This was interactive right in front of everybody. Then I started seeing the improvements. I said, let me do the data on how these kids are improving. And I found with the data that these kids were improved, double-digit improvement between 13 to 22% in just 3 to 6 months. And the biggest gains were seen in the earlier years. So I put an assessment together, and I've been doing this for about 2 years, very successful. My plan is to put it on a computer platform using AI tools so it can be done at home. And the score can be sent to the pediatrician or directly to the parent, and they can get the intervention directly. My intervention, I use AI tools. I teach the parents how to do it, to get worksheets ready each day. I just got a grant from the American Academy of Pediatrics to study English language learners to see how they benefit from my assessments. And so I have a little school set up in my office, and it's been going on now for about 3 months, and they really benefit, and especially kids from homes with less resources. Any questions?
Let me interrupt you for a minute. Hansa, do you want to introduce yourself because you're participating in this?
Yeah, absolutely. I'm Hansa Bhargava. I'm a board certified pediatrician, and I work with, have been working in digital education for a long time with Medscape, and now at Healio as the Chief Clinical Strategy and Innovation Officer. My heart is in pediatrics, so when Susan actually reached out and told me about this program, I was very excited. Personally, I have seen a lot of kids with these kinds of issues, and they get lost in the system. And when they get lost in the system, there's major ripple effects. And the ripple effects are essentially they get behind in school, but that's not all. They start feeling bad about themselves. They have lower self-esteem. And also, at the end of the day, there's been good data to show that these kids are basically have a reduced likelihood of getting jobs, getting married, have increased chronic disease, and that's where the ACEs comes in. So what Susan's doing is extremely important work.
Okay. Yeah, sure. So, Anthony, this general topic of improving literacy and fluency has come up, not just what Susan is referring to, but you've spoken a lot and promoted a lot about the so-called being bilingual without an accent. So how do you increase, or what has been your observation about using artificial intelligence to improve not just patient and child literacy in terms of language, but AI literacy for patients and for healthcare providers?
Yeah, you're absolutely right. I've been busy and more focused on the clinician side, but we absolutely need to address the families and the patients ourselves. And we actually have increasing more communications at my hospital with patients and families and about, addressing their questions about AI. So we put together an FAQ of their questions and post it in newsletters. We actually have 2 parents on our AI committee, which has been really, really helpful to give us input into what families and their children need. So, but you're right, at some point it would be nice to have AI in health for just patients and families in a more formalized and structured way. I've been doing various things, but not in a more structured format.
So I want to open the floor to anyone that has a question or share their experience. But another issue that has come up is using artificial intelligence or other techniques to provide patient education following a clinic visit in response to an online inquiry on the patient portal. So the typical scenario is you go through all kinds of brain damage to make an appointment, if you can find a doctor. But let's assume you can. And incidentally, there was a recent article that indicated that if you have Medicare Advantage, the population of physicians that are available to you are half the size as if you have regular Medicare. So let's just assume you game the system and you figure it out, and you get in network and you try to make an appointment, either for your kid in the case of pediatrics or yourself. So you make the appointment, you're seen. After the appointment, you then get maybe a clinical note. That is a post-clinic visit summary. And then this brings up the whole issue is how many people actually use a patient portal, and it's rising, but it's not very many, maybe 25, 30% of patients. But anyway, the information that you get is pretty scripted. In other words, it's AI created. And it may or may not be relevant to actually what you saw the doctor for. And it doesn't really discuss, in the case of preference-sensitive conditions, the options that you have. So then you say, wait a minute, I want to talk to my doctor. Because I saw the doctor and I'm confused. What am I supposed to do? Particularly if it's a preference-sensitive condition and shared decision-making. And then guess what happens? You get a note from the PA, who again is scripted, who doesn't answer the question. So this gets to process and people again. So my question is, given the scenario that I've just described, does anyone have any thoughts about, what are they doing to fix this? Do you think this is a real problem? Is artificial intelligence the problem and not the solution? Susan, how do you see this in pediatrics playing out?
Well,
what do your patients get after they see you in the clinic for a visit in terms of education?
They don't get a scripted answer from AI. First of all, most physicians are very frustrated in private equity or hospital groups if they're in private practice. So they don't have the time to develop a script. They're rushed. People are knocking on their doors. Okay, you're 5 minutes over. And they're trying to make things work properly. If we use AI tools to eliminate all the work that we do, I've been doing this for a long time, so I have it down and I have it really well balanced in my office. I hire people to work in my office who want to go into healthcare, either medical students or etc. And they are interested in the diagnosis and the treatment and the intervention of what has to be done. So I think it's just the environment of healthcare. Doctors don't have the time and they're overwhelmed. If we can eliminate that by giving them AI tools to take care of all of that, they can spend the time talking to patients.
Hansa, how do you deal with this?
I think we know that AI tools are helping reduce burden, especially, scribes, and we've seen the data that does that. So I do think that, to Susan's point, AI can certainly reduce that burden. But I think that as we roll out AI in all of these areas, it's really important and I think Arlen, you said it, or maybe Anthony said it, it's really important for the patient to have literacy around how to use the AI and doesn't become a barrier, for them. So, we just replace one barrier with another.
Anthony, you made a comment about agentic AI. What's the present status of implementation in your view of that?
It's still relatively primitive and few services available, but I do expect this to really take off after enough people understand what it is and understand how this can help. I just had a clinic of 25 patients yesterday, and between ambient and my human scribes, I was able to see all 25, do all of their notes, sign off on all the orders, read all their echoes, and I left the clinic around 4:30. So it is possible, I think, Arlen, with the strategic combination of human and ambient intelligence, and this is before I deploy any agentic, which we're looking into. So when I look at the things I had to do during clinic and after clinic, I would say 70% of those things could be done with clever use of an agentic tool that will just automate these processes that I'm doing, especially with referring to other cardiologists or getting lab results back and then explaining them to parents and families. I think these are things that can be really automated safely. That's the key word, is automating it safely. When you get into more sophisticated decision support, obviously that's a totally different category of agentic tools. But I do expect agentic tools to start happening by this time next year.
So, I mean, other than your boyish good looks, what do you attribute your ability to do this while other people seem to struggle to do it? Why can you do it and other people are having such a hard time with this?
I don't know. I think I think it's just the spirit of being willing to fail if it doesn't work. If something isn't working, I just try to pivot as fast as I can. I guess it's in the startup spirit of trying things that eventually will get to something that works well. I mean, I don't know too many pediatric cardiologists can see 25 patients and do what I did yesterday. And yet I've been talking about human scribes for 25 years, and yet still very few practices. Because I think, Arlen, I think the notion is if they have to spend money, they have to not do it. And I think sometimes you have to spend money to be a lot more efficient and a lot more effective. I guess people are in a mode of being in a foxhole, not willing to spend money to improve their experiences and improve their efficiency. I mean, the return on the human scribes alone, never mind ambient, on the human scribes alone was 30+% on the productivity if you're measuring RVUs, not to mention 95+% on patient and clinician satisfaction. So I thought there was very little downside, and the return is huge. It's thousands of percent, because we pay the scribes anywhere from 20 to 30 an hour. And as Susan said, they're usually pre-med students, so it's even more gratifying for us to be working with them. And they actually do care about the patients and what they do. So I don't, to me, it's a no-brainer from a business perspective. And then you can have the cardiologists, they don't have the pajama time that everyone talks about. And when they're freed up, they can read their own echoes because they don't have to be struggling with the notes. So that's why the productivity is way up. So I don't know why some practices are hesitant, perhaps just not really appreciating the huge side of the benefit.
Good, thanks. Dan, do you have a comment or a question?
Yes. Thanks, Arlen. I just two quick points. One was just a follow-up on your discussion of operations, and the second is actually a question for Susan. But just to quickly tie into what you and Anthony were just saying about the use of AI, scribes in particular, with operational efficiency. I noticed one niche area, at least in my own experience, where there seemed to be a high concentration of early adopters, and that's in areas where the expectations of the patients are the highest. So specifically with concierge medicine in New York City, I have a couple friends in one group called the Private Medical Group, and then one colleague in another group called Atria, where the patients pay X amount of dollars to be part of these networks, and they have very high expectations of exactly what you're describing, Arlen, in terms of they really want high return, not just with health outcomes, but with communication. And that means they want a very nice wrapped up emailed copy of the visit or whatever communication they just had with the doctor or someone else in the clinical team. And my friends will use any kind of scribe they can get their hands on, and sometimes not the best ones, to kind of record the conversation, and then they'll literally put it into ChatGPT to say like, hey, make a nice, beautiful clinical note, and then they just email it to their patients. And I worry that maybe that isn't the best approach, but they kind of have to because the demand is already there. But then my question for you, Susan, is, Anthony began to talk a little bit about agentic AI, and I know we all kind of think about how, certain patients maybe have high reservations to maybe speaking to an AI agent. Maybe they will be okay with scheduling an appointment, but when it comes to actually extracting information, taking a clinical history, maybe some people don't want to speak to an AI agent. And my question for you is, I have a 2-year-old daughter, great sense of like imagination, no reservations about talking to anybody. And I wonder, in your opinion, do you think children at that age, or maybe a little bit older, 3, 4, will be even more willing to speak to an AI agent just because their sense of imagination is higher? Do you think maybe AI agents may be more successful in that population taking clinical histories than the adult population?
Do you mean AI agents speaking directly to the children in the office?
Yes. Yeah, sorry, not so much. Yeah, like for instance, it doesn't have to be on a smartphone. It could be, maybe on a tablet or something. But the idea is that, well, let's say we needed to, I can't think of a specific example off the top of my head where this would be useful, but if we did need some type of agentic AI to expand our reach to patients, maybe to
Well,
take further history.
well, I think in my program for literacy or for developmental delay, picking up the gaps that the children have, I think having a platform using the AI tools that you're speaking about to get them to do certain things with a parent or a teacher with them to identify it and to give them intervention, it's very, very useful because in my office, I'm already using a prototype for a 5-year-old. And we're asking, the computer is asking the child, why do you like ice cream? What is your favorite flavor? And the child will say to the computer, I like strawberry because I really eat strawberries every summer. Or what do you like to do in the park? And it really shows us what is their expressive and receptive language ability. And then I can tell the parents, hey, you got to work on this receptive. They're just not picking up. Or we need to work like, how Miss Rachel, she has all those little cartoons. Well, we do little things with the letter sounds. Okay, what's this letter sound? And the child gets it wrong. We don't say it's wrong. The computer says, let's try it again. Let's try it this way. And it's really improving their ability to become literate. And that's what the schools are having a difficult time doing, especially in populations where English language learners or homes with less resources. The equity problem is really big in education. If we could solve that by having something online, that would be great. Pediatricians don't have the enthusiasm to do it because they haven't been told that. But I feel this should be a standard of care for every pediatrician to evaluate these issues interactively in the office.
Susan, excuse me one second, Hansa. Susan, are you being paid to do this? Are you getting reimbursed
Yes.
for what you're doing?
Yes, I am. I'm getting paid pretty well.
Okay. Hansa, you have a
Yeah, I was just going to say, like, it's really interesting what Susan said about the inequities because it's not just, I think, English as a second language, but I think the other inequity that we don't talk about as much is time. Like, parents that are trying to put food on the table, 1/4 of our nation of parents our children are food insecure.
Oh, for
That means
sure.
both parents and 50% of kids are single parented. So that's like huge. So, I mean, I feel like our group probably our kids have that time like wealth from us, right? Because we are able to adjust our schedules to have those conversations with the kids. So that's one aspect, I think, that is a macro problem. And then the second aspect I just wanted to point out is just and the American Academy of Pediatrics has done a lot of research on this in their Center of Media and Mental Health about social media actually taking time away from that very little time that parents have. The parents are scrolling. The parents are actually on their phones. You can walk into any restaurant and you don't see people talking to their kids. They're actually talking on their phones. And I'm not blaming them. I think we know that there's a dopamine pathway there and it's very addictive. And also, parents who have a rough life, and I know Susan's seen these parents and so have I, like it's very hard for them not to have some distraction that they get some pleasure out of, right? Otherwise they're just working all the time, taking care of the kids all the time. So I think the time equity that is a huge thing. And that's where, just like time equity is a huge thing in clinical practices, and ambient listening has actually helped that time equity because the doctors are running on time deficit. Similarly, I think parents are running on time deficit, and perhaps AI, like what Susan's describing, where the AI actually, like a safe, effective AI can actually talk to the children. They can actually do these things. Because Susan, I don't know about you, but When I saw parents, I'd be like, oh, well, you have to talk about them. You have to have this back and forth with them conversation. And they're like, yeah, yeah, yeah. Do you think that happens when they leave the office? No, because they're just trying to put food on the table.
Yeah, no. So that's why in my clinic for the AAP grant, we have a Zoom class that goes on the same time as in person. The teacher's going crazy, but it's working. These kids, our parents work 3 jobs. They can't come in to my class. So we're doing what we can to do the outreach to help everybody, those that can afford it and those who can't.
Um, so Dalen, can you tell us a little bit about what's going on at the University of Colorado?
I don't know.
Hey there, was I just mentioned? Sorry, I'm getting ready for work.
Yeah, could you just tell us who you are and you made a comment about Colorado, so obviously it piqued my interest. So could you just briefly tell us about what's going on in Colorado?
Yeah, hey Arlen, nice to see you again. I'm a 3rd-year resident in pediatrics and genetics at the University of Colorado. I've been a part of the GME education subcommittee and been a part of the discussions of incorporating AI technologies ethically and safely into our training. And I have been attending the AI in medicine conferences for the past couple of years. I'll be there in a few weeks. Did the ABAM certification. I'm very interested in these technologies, especially with regards to rare disorders. I'm currently working in the Center for Health AI, doing research in biomedical informatics with metabolic rare conditions. And so this area is particularly interesting to me. AI in medicine as a whole, from an operations standpoint, from a personalized medical education standpoint, from an efficiency standpoint, access, all of the above. So thank you for having me here. I'm delighted to be a part of these conversations and just be a fly on the wall.
It sounds like that the residents are enthusiastic about all this stuff, and you're seeing some significant impact.
Residents and faculty alike, there are always those that are going to be a little bit reluctant in terms of the adoption of these technologies. Maybe they already have a system in place. They've been in practice for 20 years. I have a lot of discussions with faculty that are resistant to using these technologies and are concerned about these technologies taking over our jobs and our roles. And I think there are broader discussions around how our roles can shift with these technologies incorporated and how medical education can be shifted as well, how we think about it from rote memorization to application of critical thinking and competency exams based on the application of highly complex information. But all that to say, it's a wide spectrum, as you know, and there are always the early adopters, the late adopters, those that are reluctant and resistant to it, those that are concerned about it. And it's just a broad discussion. And I am very hopeful that we can have some sort of regulatory body overseeing the adoption of AI in medicine. I don't currently see that for the United States. I think that that's sorely needed so that we have ethical adoption of AI into our healthcare system. And use it for the good that it has the potential for, instead of potentially using it to make people just more efficient and return more on investments, etc. So there's a lot to be said in this space, but I would say, to answer your question very directly, residents and trainees are very excited about these technologies and have already been adopting these technologies since medical school before they even came to residency. This is just something that we've been waiting for a while. Now it's coming, and there's a lot of reverse mentorship happening.
Right. That was my next question. What about the faculty?
A wide spectrum, as I said. Some are embracing it, adopting it into their clinical practice, and seeing a lot of the efficiency that Dr. Chang was just mentioning. Others are more skeptical and less enthused by technological advances and more resistant to incorporate that into their workflow. There's a wide spectrum. But I would say, by and large, people are starting to use it and embrace it at our institution. We have a culture that is excited to incorporate these technologies, and it came from our leadership, from the top down, as well as from trainees and faculty alike from the bottom up. It was a cultural shift at our institution that is still ongoing, and very excited to be there today.
And my final question is, one of the barriers to implementation of this is if it's not on the test, we forget the rest. So the question is, as accreditation and testing evolves, whether it's from the ACA, the ACGME or the AANC or ACOM or whatever, are you seeing questions concerning the use of technology generally, and more specifically artificial intelligence, in competency assessments, OSCEs, board exams, that kind of stuff?
I don't see these technologies being incorporated into board exams and competencies like I think they should be. However, we are using these technologies to, I think if your question was, are we using big data and these types of technologies to evaluate trainees? Yes, that is rolling out. In terms of the concerns around over-reliance and dependence on these technologies and the lack of development of core competencies, that is something that is actively being discussed, and we are considering it as we roll these things out in a tiered fashion. And that's something that we're going to continue to monitor moving forward. But part of what we are doing to combat that is training on the ethical use and responsible use of these tools in clinical practice.
Great. You got a big following. Hansa's a new groupie. So
I'm a groupie, Dylan. If you don't mind, I did link into you, but I do want to talk to you offline. If you don't mind emailing me.
Great.
Of course.
So Justin Lowell, you're involved in process mapping, and we've heard now some low-tech solutions. We've heard some high-tech solutions to education generally, whether it's kids, patients, doctors, providers, the whole ball of wax. So from your perspective, what insights can you share in terms of this issue of fixing the process before you attempt to digitize?
I mean, I think that's good guidance. I think there's a spectrum, following Dalen's vibe about this. The spectrum, I think there's a broad spectrum of how AI can be used in some of these settings. And I think instead of boiling the ocean of what is possible, taking on discrete opportunities offers a pathway for less hallucination and better risk mitigation, while still capturing some of those productivity gains.
But more specifically, what should someone do to start with looking at workflow and process mapping?
I mean,
Because
right,
it doesn't make sense to digitize stuff that is just getting in the way. It's garbage in, garbage out. So
right.
what's the one thing you would recommend a person listening to this podcast do to try to fix?
I mean, evaluate your process map, zoom out to zoom in, if you don't have one, build one. We talked about it at the last chapter meeting, right? That the importance of having not just any old process map, but something that's been well considered, evaluated, and then ideally, optimized for the outcomes that you're looking to drive patient first.
Okay, so another question I have for the pediatrics groups and for others is, how does all this play into the neurodiverse population of kids? My understanding of autism and the spectrum is really pretty abbreviated, but my understanding is that those kids seem to do better working on computers and interacting with interactive media. Is that correct? And what are your thoughts?
First of all, we want to pick up anybody that could possibly be neurodiverse, not to change them, to take away who they are, but to help them with any deficits that they might have as a pediatrician. That's what Hansa and all of us are doing actively, starting early as 18 months of age or even earlier. We're just zeroing in on what is it that the child has a gap in and fixing it. So when you're saying the computer, I agree, Arlen, that's very good. We have to have more, like with Soundwise for Kids. My goal is to pick up these things and give them intervention on the computer for everybody, for parents, teachers, and pediatricians to use. And yes, that will be very helpful, but you can't leave them alone with that. And it has to be monitored, it has to be safe. And that's the issue with parents. They want something like that, but safe, that they can depend on.
Hansa, you have any? Hansa, you have any thoughts?
No, I mean, I would agree with Susan on those points.
Okay, Harvey, comments or questions?
Yeah, basically, congratulations on the entrepreneurship. Obviously, Arlen and I and Chang all appreciate that. And what can we do for our patients? And I love hearing what you're doing. And I'm glad that Arlen asked, are you getting paid? Because if we can get reimbursed for, more likely it's going to spread quicker as opposed to bootstrapping it and nobody's paying for it. So it gives me hope to see that then, if that's the case, then we should be seeing this more around the country.
Yeah, you mentioned, it's too bad Sharif's not with us, but I think most of you know Sharif Tarman. He's the CEO of Cognoa, which is a software as a medical device platform to early detection of autism. Susan, do you have any or anybody else have any comments? Have you used that? I think that's a good idea. What are the issues?
It's an excellent idea. It's just that there's a cost problem. They're trying to get insurance companies to cover it. So that's the big issue. If insurance doesn't cover it, how can a parent afford to do it? That's the problem. So that's why people like Hansa and myself and other pediatricians are working really hard to educate other pediatricians to pick up things earlier, to use AI tools to do that, especially before they're entering school, so they don't suffer and have those mental health disparities that we're seeing. And social media adds to it. If you're not doing well in school, you're going on platforms to get confidence, to be visible. And that makes you feel better, because if you can't raise your hand in kindergarten or first grade or second, and teachers calling on those who are so that decoding comes easy for them, you really feel like a loser. So we really have to do better with our children to make them go in confident. And that's going to be important for our nation. Just recently, in this past year, some of my patients were thinking of going into engineering or into medical school. Before that, a lot of kids were just so disillusioned. I don't want to go to college, or I don't want to even go for a skill like HVAC or anything like that, because they don't feel strong. We've got to do better in this.
But what can you share about how this is done in China? You mentioned that they don't use AI scribes, but we're curious. So what do they do?
Well, if you've been to a clinic, in a typical clinic in China, they see about 10 to 15 patients an hour. So, and to me, and they just do handwritten notes right now. And to me, what a great opportunity for them to have ambient, because they can supplement it with additional things, because their demand to see patients is so much greater than here in terms of volume, sheer volume. So they are going to look into it, because they hadn't even really heard of it when I talked to it was a diverse group of doctors in different hospitals.
So way back in the day, when I was attending at a university hospital, we saw about 10 to 15 patients an hour. And the way we did it, of course, this is, a million years ago. But the way we did it was there were 4 or 5 residents in the clinic. There was a very well educated and talented PA who just did pediatric otolaryngology. And I was the attending, and my task was to basically go from room to room to room and debrief what the issue was. But more importantly, the workflow, and this gets to the workflow at the time was, 50% of the patients didn't have a chart because somebody was stacked it in our office or it was lost in what we used to call medical records. So again, literally, we were writing notes on 3x5 cards and on pieces of paper. And secondly, my role was to hand stamp. I was issued a signature stamp that, in the old days where you put it on the pad, the ink pad, and you stamp it on a piece of paper. And that was it. That was just the proof that I was there when it happened. So, and actually, now this is just my specialty because a lot of it was acute care. It was a one-off visit. And then if the patient needed surgery, and I think this is the way this works in China because I've seen some of this, is, there's a pretty strong hierarchy of the professor who does most of the surgery. And it sort of gets turfed up a food chain. And if you need an operation, maybe that person or that person's assistant would pre-op the patient, so to speak, and then they wind up in the surgery. My point is how much, again, it gets to regulation and rules and all that other stuff that somehow has found its way into the workflow process that prevents us from seeing so many patients. I mean, is that what you see in China and all the other places you've been to? I mean, Turkey or India or whatever.
Actually, don't think it's mainly regulation. I think it's just a mindset, and that's why it's so good for me to see how AI in health is practiced in different countries. I'm actually putting a white paper together with Mohammed Mamdani. You might know him from University of Toronto. It's even very different in Canada compared to the US. So it's the mentality of the clinicians, the mentality of the society as a whole, and how you look at AI. In China and India, those countries are much more, I think, open to new tools and AI as a society, not just as the healthcare sector. So I think our biggest impediment to adoption is still the overall societal attitude about AI. And even Canada is now more ahead in terms of societal adoption and trust in AI. So it maybe just takes more education, more time to trust these tools. But I think, thank goodness for ambient in the last year or so, because I think that's reviving some of the momentum that we gained through the use of large language models.
Anthony, that's so interesting about like the cultural attitudes in these countries versus the United States. I mean, and that's, I think you're talking about the general population, not just physicians, right?
Right.
Yeah. So, I mean, is that?
It's both in a way, because obviously physicians are part of the population. And as a matter of fact, I forgot where this paper was basing the study from, but there was an even added to recent paper that published about how clinicians look at clinicians who use AI less favorably than clinicians who do not use AI.
Wow.
I think that was an American study, actually. So it's a double whammy, right? Because we those physicians who like to use AI, in a responsible way, suffer from societal adoption issues as well as their peers not trusting AI. So we have a double challenge. But on the other hand, I think that that will get better and better. In China, it's the opposite. They have great societal adoption. The clinicians, however, ironically, are a little bit behind in terms of adoption of AI, just because they haven't had a wealth of tools available, and also their startup scene's a little bit more chaotic. But it's coming down from the central government to adopt DeepSeek, for instance, across hospitals. So their advantage is that they have a centralized system in which it's, as opposed to 50 different ones here. So once the order comes from the top in China, then there's, very, very good adoption across the board and across hospitals.
I think in my office, I really work hard in educating the medical students, residents, NPs, and the PAs to understand the importance of AI as a tool And then we translate that to the patients. We allow them to feel empowered to use it, especially AI study mode for students. We talk about that. We talk about Google Notebook. A lot of the patients, even though I work in an area that economically they are educated, a lot of them are afraid of AI. So it really comes down to us as physicians, not only to other physicians, but to our patients. How do we educate them? How do we get them on board?
Susan, what advice would you give? Now, what I hear is that you're using a relatively low-tech approach to do this, and we haven't discussed, the outcomes in terms of statistics and all that. But in terms of moving forward, where do you see this going in your office? And what advice would you give to people who would consider doing something like this or want to put a toe in the water?
Well, I'm trying to get an SBIR grant and other money funding to get this on a computer platform so that pediatricians can email this to their patients at home and it can be scored and the results come back to the pediatrician. They can discuss it in their office. Or I want it in every preschool. So what advice do I have? I think as doctors, we have to not worry about, don't sweat the small stuff of like, oh, I can't get this on time or I can't do this. Think about why you went into medicine. You're there to be innovative, to really give to your patients, to your colleagues, and think of how do I solve these problems? Join organizations like yours, Arlen or Anthony, and learn and take those tools and use them in our offices to do better for our patients and ourselves. So anybody who wants to use my system, you're welcome to notify me and I'll be glad to give it to them. They can use it in their office on paper for now. And when I get funding, I'll give them the computer version.
Okay, so let's talk a little bit about this barrier to, you said that the next step is to, quote, computerize it. So what do you mean by that? I mean, are you looking for a software engineer? Are you going to build a company? I mean, what is the next commercial? Are you thinking of a commercialization step? And if not, what's next? How are you going to do this?
Well, I go to talk to people about getting funding, applying for government grants. That's how I'm going to do it. And I go to Anthony's programs and learn about how AI can do this for me. And I'm learning. I'm using, I have an MVP by a colleague of Harvey Castro who helped me put together a demonstration how it can be done on a computer using AI tools. And I'm practicing with that with the kids. Yes, this is a company. We're looking for funding. We want to get it online. And so it can help a lot of people, scalable, and reduces the inequity issue. That's what I'm working on.
Good for you. So this issue, so this gets to the entrepreneurial translation of this idea. And this issue of, just yesterday, I got a request from someone, I have an idea, I need a software engineer, or I need someone that understands how to put together a website or a mobile app or some sort of platform, whether it has anything to do with AI or not, to do this. And then the issue comes up for a clinician. Well, I don't know anybody who does that stuff. How do I find somebody? What questions do I ask? And so has anybody in the audience had that experience and found someone that could help them actually build this thing that they can share with the audience? And what should you ask? Anybody have any thoughts about that?
Say it depends on the needs requirements. So that would be a conversation with Susan about maybe the data that goes in, how it's collected, then what's intended to go out, right? I heard there's an email that then goes out, but like really understanding how the data comes in and goes out is something I'm familiar with, that I understand is important, and probably also some compliance questions in that same vein to understand how you're going to deliver end to end.
I don't think you introduced yourself. Justin. I'm not sure what you do.
Yeah, sorry, I'm Justin Lowell. I work here at IntelliStack, formerly known as FormStack. I'm a sustainability entrepreneur, MBA from here at CU is part of my journey and part of my fabric. But I came here to, when it was FormStack, to save people time, how to save people time at scale. So my comment in the chat about like, hey, this is how we're using our technologies to try to help clinicians have more surface area with patients in a meaningful way, and that we've kind of helped to deliver these outcomes with some of our tools in some of these contexts. When you were talking about your use case, it reminded me of a conversation I had here when I was a seller, but I'm now in a partnership function. So I manage our partnership with Salesforce and about 15 other strategic SI partners or system integrators who would also be people in that realm of the builder space that you're looking for. So some of them might even be able to help.
You have some suggestions how to close the clinician, data scientist, data engineer gap?
Communication, put people in a room. Have the conversations, more stakeholders.
So one way to do this is, Susan, my understanding is you're going to be at AI Med, you're going to be presenting some stuff, and that's a great place to sort of schmooze. This really is about just connecting dots and, what are your needs? Have a conversation with someone. What is it going to cost? What is the deliverable? What are the issues? Who owns it? How long is it going to take? What about follow-up? I mean, there's a whole list of things that maybe another session will deal with what do you ask the data scientist? Or not even that, what do you ask a software engineer to build something for you that solves your problem and that is affordable given what you're trying to do. But that's my initial suggestion in terms of doing that. And the second is you need to do a much better job of networking with these folks, whether it's however you do it. I don't care whether it's chapter meetings or LinkedIn or just going to their meetings and just meeting these folks and familiarizing yourself with, it's a lot like hiring a contractor to build an addition on your house. Right. Like, here are the specs. Here's what I'm trying to do. Here's all the stuff. What's it going to cost? How long is it going to take? Et cetera, et cetera, et cetera. And finally, my general observation is that when you get into this, the analogy I draw is like renovating your kitchen. It's going to cost twice as much. It's going to take twice as long. And when it's done, it's still not going to be what you originally wanted. They put the switch in the wrong place or the cabinet doesn't work, whatever. So you sort of have to build in that wiggle room and understand that you got to give yourself some leeway. So you're really sort of looking at a low estimate, high estimate. And again, who owns it is an important subject, because if this is work for hire, that's one thing. If it's not stipulated, and that means I'm hiring you to do something, but once you turn it over to me, I own it. Because there have been instances where all of a sudden your website shows up and somebody else has the URL, and guess what? You don't own it anymore. So you have to worry about the IP issues and those sorts of things. So
I didn't mention, Arlen, I got a patent for my work, the way I'm presenting it. Using all the domains together, I got a patent for the U.S. Patent Office. So that's really exciting. So look, after being on this podcast with you, Arlen, Anthony, and everybody else, I'm going to really get into the social networking now. That's something that I really was a little shy about, answering questions. And I'm seeing 40 patients a day. That's a lot. So I'm trying to manage everything. But that's a great point, Arlen. I have to be more socially active online, and I'm going to work on that.
Good for you. Elon, do you want to give us a final comment? You're pretty good at keeping us toe to the ground from the patient perspective. Can you give us your 2 cents?
Well, thank you. As an older citizen of this country and as well as a world traveler, I witness, healthcare systems in many, many places. I can just tell you that from my personal perspective as a patient, my healthcare system here just changed from one system, one technology platform or whatever it was to another. That created a lot of confusion. It created a lot of negative responses. And I also see it in other areas like the education area where universities are changing their technology platforms. And suddenly everybody who just got used to use one platform, suddenly they have to move to something else. A lot of confusion. It creates also a little bit of negativity. Now, the group I'm looking at on the screen right now is a group of very, very brilliant people who mean well, who ultimately can really save humanity. But my concern is, how does it filter? How does it go from the few ones who are the geniuses, the inventors, the visionaries? How does it go down and filters into the population out there? And Anthony, you just put a chart before about how different countries adopt technology, for example. And I believe in that. There is a huge difference between the ways certain populations adopt it and implement it versus others. We unfortunately live in a place where we probably have the best research, the best innovations in the world, but our population is so diverse and so polarized and so managed by political budgeting, and that it somehow it dissolves in the middle, and it doesn't reach us, the patients. So I wish it would be better, but I'm just expressing my frustrations because I'm totally open to AI. I want to use it, and I don't know how.
Okay, that's a great perspective, but I want to end this on a positive note, and that is that if you look at the history, I just came back from a trip that one of the places we went to was a place where the Industrial Revolution, that is in England, last one, was started. And I guess my observation is, if you look at the history of industrial revolutions, going all the way back to water power and the mill to where we are now, people describe it as the fourth industrial revolution, sometimes the fifth. There are always these lags in adoption by the general population, but it happens. So I guess my positive note is it may take a while, but if history is any guide, the adoption is, just look how rapidly ChatGPT was adopted by people on a cell phone. It's going to happen. The second point is we have no idea what it's going to look like. And I constantly bring up this issue of the iPhone was launched in 2007. Could anyone have predicted what we know now, then what impact the iPhone would have on our civilization? The answer is no. So, Susan, final word.
Yeah, I just want to say that we have to start from small. For example, in my office, I've done such great work. I've helped so many kids. I look at them as our future leaders, and we've got to start where we are. And from there, I go to the meetings and I try to educate others that have done such great work, such positive work, Elon. So I feel I'm doing my part, and I think all of us have to do the same, and that's what we're doing.
God bless you. I agree with you.
All right, this has been a great conversation. Thanks for everybody's input and advice and guidance, and we'll see you next time.